perfectly.
All right, great. Well, thank you. Thanks to the department for giving us an opportunity to present our work here today. And we're off. Slides are not advancing. We're off like a herd of turtles here. Slides not advanced. There we go. All right. Okay, so here's our disclosure slide. So today we're going to talk about the CORE project. CORE stands for Carolina's Opioid Reduction Effort. And this is a multifaceted initiative. We started about 5 years ago. It has different components, but one of the main focuses of this project was on clinical research and finding ways to curtail and minimize the use of opioids in our patients. So just a little bit of an outline. We'll first start with why we're talking about this and why we put so much effort into this project. We'll look at an interesting backstory that has to do with a patient of mine and how we came up with the idea of doing the CORE project. We'll talk about the initial pilot we did, which involved shoulder surgery, and which laid the groundwork for our current CORE study. And then we'll go through the current design and the protocol of the current CORE study that we're enrolling in now. And we'll take a look at the results we've seen so far, and then we'll finally look at where we plan on going moving forward with this project. So we'll start with why. Why are we talking about it? Well, before COVID, it was pretty easy to throw around the term epidemic. It's a little harder now, but I would still argue that the opioid problem in the United States has absolutely reached epidemic proportions. Just as a comparison, you can see when I made this slide, there was 115,000 deaths in 2020 from COVID. And in 2018, just to keep things in perspective, there was about 67,000 deaths of Americans from opioid-related overdoses. So I mean, it is not nearly at the proportion of a viral pandemic, but it's also not a small insignificant number either. It's actually past car accidents and taking more American lives per year. But the most frustrating thing in my mind about the opioid problem in the US is I find it to be 100% iatrogenic, and that being defined as being caused directly from medical treatment. So half of all opioid overdose deaths in the US are from a prescription opioid, so given from a provider. We see that 75% of ER visits are from opioid overdoses that are from diverted medications. And that's an important thing to understand. When we first started presenting this idea, you know, we heard some feedback like, look, you know, my 82-year-old sweet ladies are not going to abuse opioids, or my patients have an elective bunion surgery. They're not going to be the ones that we have to worry about. So this doesn't really affect my practice very much. And to some degree, they're correct. You know, those patients are probably not going to be the ones that have a problem with opioids. But what happens with those patients is they take about 2 of their 80 pills. The rest of that medicine bottle goes into their house in their bathroom, and well, their granddaughter or their nephew or their plumber, somebody gets their hands on the unused opioids. And that's where we see a lot of the opioid overdoses is from diverted medications. So we'll talk about this a little bit later, but diverted prescriptions are a huge problem, and that's something we really wanted to focus on with this project. So this slide basically just shows how the opioid issue has evolved over the years, and you can see how it's literally rippled through the United States year over year. And you can see there are hot spots in the US, but this is something that has infected our entire country. And it's affected really just our country. This is a United States problem. 5% of the global population and 75% of the opioid consumption is here in the US. And for us here in North Carolina, this is something that's really right in our backyard. 4 of the top 20 worst cities in the United States for opioid abuse are here in North Carolina. So this is without a doubt something that's affecting our patients and our communities here. So why are these medications so addictive? Well, if you look at 2 of the more commonly prescribed opioids, oxycodone and morphine, and I I would bet that almost every provider has prescribed one of those two in the last week to a patient. You know, the chemical composition is very similar to the compound in the middle, and the compound in the middle is literally street heroin. So, you know, it's not too far-fetched to say that we're essentially prescribing legalized forms of heroin derivatives to our patients. And are they addictive? Well, yeah. You know, 50% of our patients that are taking opioid medications 3 months after a surgery are still on those medications 5 years later. So how did we get here? How did we get to a point where we thought that it was the best thing for our patients and it was considered the standard of care to give patients these medications, these highly addictive medications, to recover from elective surgery? If you haven't heard Dr. Shi give this talk, this exact talk of how we got here and sort of the history behind how opioids became introduced into the U.S. healthcare system, I would encourage you to look out for it. It's a fascinating talk, but also very frustrating to hear. And as you can imagine, it all started with money. It started, you know, opioids have been around a long time, but in the 80s and 90s, we saw that pharmaceutical companies and various pain advocacy groups and quote thought leaders were really starting to turn the screws and lobby hard for a decrease in the regulations on how opioids were used for patients. What we saw was their lobbying was extremely successful, and they were able to get far-reaching organizations like JACO to make pain the fifth vital sign, and to make pain a huge criteria for how hospitals and practices and physicians are benchmarked. And what that led to was a huge stress on doing everything we could possibly do to reduce pain levels in our patients. And everything was about trying to keep patients more and more comfortable, which sounds great, but how are we going to do that? What medications do we use? Well, introduce direct consumer advertising, strong marketing, and now you have medicines like OxyContin, Percocet, and hydrocodone being used with very poor evidence to support its safety or efficacy. So this happened in the 80s, 90s, and 2000s, and really what had happened was you have now opioids that are now considered as the standard of care for management of acute and chronic pain nationwide. And it really wasn't until 2008 and 10 and 12 where we started to see our healthcare system smarten up, and we start to see government agencies like the Attorney's Office and the DEA start to slap the wrists of pharmaceutical companies, and you start to see some indictments coming out about fraud and misleading the healthcare community on the safety of opioids. But at this point, the damage was done, and you had opioids that were here to stay, and you had it as by far and away the preferred choice for pain relief for both acute and chronic pain. And so this is, well, before COVID, this is what usually we saw when you picked up a magazine or watched the news. Everything was about the opioid epidemic and the opioid problem in the U.S. And I think we're at a point now where everybody knows where we are. We have a huge problem on our hands here with it. And the real question is now what are we doing about it? And I thought it was interesting. A letter from the editor of JBJS a few months ago said in no uncertain terms that, listen, we're not really interested in reviewing more manuscripts that talk about how bad the opioid problem is in the U.S. What we're interested in looking at and what we want to publish is studies that help us show how we can mitigate the problem. And so that brings us to the initial aim we had for our core project, was to identify ways that we can minimize or eliminate opioids so our patients can recover comfortably from surgery, but also safely, and to minimize the pitfalls that opioids carry with them. And so we want to try and look to see if we could find alternatives to opioids. And so this is the pilot study that really started this idea. And this was not my idea. This was a patient's idea, actually. like a lot of research ideas, the patients give it to us. And this is a patient that I did a shoulder replacement on early in my practice. And he was about 48 at the time, a banker in town. And he did well from the shoulder. We lost touch after about 6 weeks, but he was cruising with everything and came to see me several years later with his other shoulder and wanted to get it replaced. And we kind of went through the usual routine. And he said, "Hey, doc, before you go, I need to tell you that I had a real problem with the pain pills after that first surgery." And he tells me a little bit more about it. And turns out that he had a real problem with them. And he ended up moving on to other types of drugs that he was taking, and ended up losing his job, and he got a divorce, and he was in a dark place for a couple years, and he's now much better. But he had a request of me. He said, "I want you to do this shoulder replacement with absolutely no painkillers." He said, "I'm done with them. I can't go back there again. I know it's a big ask, but I want to go zero painkillers whatsoever." And he asked me what I thought about it. And at the time, I told him I thought it wasn't going to work. I thought it was going to be a mess. We were going to have to give him rescue opioids, and I didn't think it was going to work for him at all. And he was really adamant about it. So we did some things and arranged some things. I was planning on keeping him in the hospital 4 days. We were planning on repeating his nerve blocks, and as you can imagine, we did it, and everything went fine. He took ibuprofen and Tylenol and put some ice on his shoulder, and did not have one single pill or cc of any opioid at all. And it got me thinking a little bit, and I actually looked back at what I gave him for his first replacement. And this is the prescription. This is a screenshot from his chart, and that is the prescription I gave him. Percocet 10s, 100 pills. And why did I do that? Well, at the time, that was kind of what we did. This is what my fellowship mentors did. This is what my partners were doing. Everyone would tell you, "Oh, look, we don't want to give them too little, then call the office." And, it just seems like poor care to have a patient run out of pain medications while they're recovering from surgery. So always give them more than too little was what I remember. But it really got me thinking a lot about him in particular. And I felt a significant sense of responsibility for what happened with him after his first surgery. And it really got me thinking about what are we doing with our practices, and what do we need opioids for? And if you look at it, in my practice, opioids were a staple of every step of the perioperative period. Patients get opioids during their nerve block. They got it for any fluctuation in heart rate or blood pressure during a surgery. They would get opioids in the recovery room just for an anticipation of pain. If the patient goes to the floor, if they have any pain scores above 6, they're definitely going to get an opioid. And then certainly at the time of discharge, patients are getting opioid prescriptions. And sometimes we'll mix in other things, but these are opioid-centered pathways. And it got to a point where you would see a patient after surgery, and you could round them on the floor, and they can barely open their eyes. They're throwing up. They're unsteady with therapy. And I remember thinking, "Oh, they're just recovering from surgery. This is routine surgical recovery." Well, it's actually not. Looking back now, they're not recovering from surgery. They're recovering from all the slugs of opioids they had in the last 24 hours. That's what they were recovering from. And so the question now is obvious: are opioids needed? Are opioids needed at all during any of those phases? And so we thought we would take a look at it. And Dr. Connor and Schifrin were game, and we thought shoulder replacement would be a great surgery to try this on. These are usually tough patients. They've been through it. They've had hips and knees replaced. And we worked with several people. Dr. Lees was an upper level resident. He helped build these pathways. We did some exhaustive literature searches, and Catherine Chance was a champion for us with the anesthesia group, and she really helped convince her partners that this can be done. And so we built a clinical pathway, and this was our research question: can we design a safe, effective, and predictable pain management pathway for patients having shoulder replacement that does not depend on opioids whatsoever? And so our overall goals were to reduce inflammation. We were aggressive with NSAIDs. We used pain medications that decrease nerve pain signaling. We were aggressive with regional and local anesthesia. And it took some buy-in. And a lot of people, honestly, were against this. We got a lot of pushback from nursing staff and hospital team members that we're trying to torture our patients and that we're trying to make them suffer more, and it's not right. And so we'll go through the details of the protocol in a little bit, but we built this pathway, and we enroll patients in a prospective study, and this was patient-selected allocation. So we simply asked patients, look, we got a new thing we're trying. It's completely opioid-free, and if you're game, we'll include you in that. If you're not, we'll just put you in our standard pathway. So patients decided what group they wanted to go in, and we thought that was the best way to try this out. And we were fairly selective. We wanted to make sure that patients didn't have any contraindications to using the NSAIDs or to regional anesthesia. We did this prospectively, so we're able to really look at their pain scores. We look at secondary outcomes as well. And we ultimately ended up enrolling 66 patients in this study, and these groups were not completely matched. There was a little difference in the comorbidities and the preoperative pain score, but these patients were elderly at around 72 years old, and 66 patients total, evenly distributed between the two groups. There we go. And so this is our result. Our primary outcome was pain at 24 hours. And essentially we found no difference in the pain scores between the two groups. You can see the gray line here is the opioid-free group, and no statistically significant difference at really any point in their postoperative period with regards to their pain levels. We didn't find any difference in the secondary outcomes. So we didn't find any difference in nausea, delirium, or falls, constipation. This is an important slide. What we found was it worked. We did not have a lot of patients at all that had failure of the opioid-free pathway or that had to be converted to an opioid medications or an opioid-based pathway. In the opioid-free pathway, only 4 morphine milliequivalents were used in the entire cohort. And so very little need for any rescue opioids in that group at all. So this was a limited study, and this was a non-matched patient comparison. But we felt confident that what we found was an opioid-free clinical pathway that could be used for shoulder replacement in properly selected patients. And properly selected patients essentially means patients that select themselves. And so we thought we were onto something with this, and we thought, well, what do we want to do next with this, and what are our options? And several of us thought a little bit, and we said, look, Ortho Carolina is in a unique place in that we felt that we were really poised well to drive change on this problem. And like I mentioned earlier, North Carolina is a hotbed for this, and we felt sort of a sense of responsibility to be able to really be leaders on this. We wanted to collaborate with our healthcare systems, and we really needed to have a philanthropic sponsor to help with this. And that's sort of what we were able to accomplish. We partnered with Atrium Health, and we were very fortunate enough to receive a gracious grant to do this project by the Duke Endowment. So then we launched this core project, and we had different aspects of the project that we wanted to focus on. And one was raising awareness of the opioid issue, especially here in the Carolinas. And that was to patients and providers and hospitals and even payers. And we also wanted to do clinical research to demonstrate that we were able to find alternatives to opioids. And so we embarked on this large-scale prospective randomized controlled trial. And what we did was we had physician champions in each of these specialties that were, they were just as passionate as I am about this issue. And we identified one surgery in each of these specialties. We did not include pediatrics at the time, although I think we're about ready for that now. And we wanted to also focus on elective surgery where we can really talk to patients in a very non-stressful environment and be able to properly enroll and consent patients. And so we selected one surgery from each of these areas: ACDF for the spine, CMC arthroplasty for the wrist and hand. We wanted to continue the work with shoulder arthroplasty, total hip arthroplasty, routine knee scopes that were just for meniscal debridements, and then midfoot fusions. And again, we were fairly selective on exclusion criteria. We wanted to be sure not to include patients that had contraindications to taking a lot of the medications in the opioid-free pathway. So a lot of the patients on anticoagulants were excluded from this study, which for a lot of the elderly patients, this affected many of those. This was a randomized study. This involved a huge commitment from our research staff to enroll patients and to educate them about the research study. And patients were randomized a week before the surgery. And they were either randomized to the control group, and the control group was simple. It was essentially the historical pathway that each of those specialties chose as the routine recovery protocol for their patients. And that had some variability between each of the specialties. For the intervention group, and this is a protocol paper we actually just submitted, this involved several things. And the first and extremely important part was to just first educate patients on the dangers of opioids preoperatively. And this has been shown in multiple studies to in and of itself, minimize the use of opioid consumption postoperatively. So this is a conversation between the patient and their physician, the patient and the research staff, and they also all watched an introductory video that we did to introduce this issue to them. And then for the medications we used in this protocol, we didn't use anything magical. There was no experimental medications. This was stuff we've been using for a long time. In fact, probably the most controversial medication we used in this pathway was gabapentin. And gabapentin, we did an exhaustive search on what we thought gabapentin would be able to accomplish. And we found that it had a fairly safe side effect profile, although you can hear anecdotal stories about gabapentin, and we hear them all the time. But the literature supported safety. The efficacy was in question, and it really didn't really have much of a benefit in a lot of multimodal opioid-based pathways. But this was never been tried in an opioid-free pathway because there really hasn't in orthopedic surgery never really been tried a completely opioid-free pathway. So we thought we should add it. And we did so with a fairly low dose. So these other medications we initially used IV Tylenol, but as the preponderance of evidence supported, really did not show a difference between PO and IV. We've transitioned to just strictly PO for the most part. Intraoperatively, patients received either a combination of local injection or regional anesthesia. IV Toradol was given right after the surgery. Dexamethasone was given throughout in the opioid-free pathway. Postoperatively, we were really aggressive with icing. Everything except the neck surgeries received significant icing. Again, we used the Tylenol schedule. Toradol was scheduled for the inpatients. And then if the patients were going home, as this was an outpatient surgery, they were discharged home with PO Toradol. So a fairly aggressive NSAID protocol. So importantly, no patients were given a rescue opioid upon discharge. And when we first started this was a big point of contention with some providers. They didn't want their patients going home and getting stuck with having uncontrollable pain. But we thought it was a huge benefit of this idea was to decrease unused opioid stores. And so if you decrease the prescriptions, you decrease the diverted medications. And so we stuck with this, and now it's easier. Now we have system-wide electronic opioid prescriptions. But when we started the study, we didn't have that. And so it was a little bit of a leap of faith for a lot of providers to commit to this, but it was a really important part of the protocol. So here's just a look at the results we have to date. So we're still enrolling patients in the study. We've enrolled 320. Greg did a little bit of a data analysis for us with the first 242 patients. And this is sort of what we have so far. So we have 116 that have been enrolled in the control group, 126 in the opioid-free group. And the groups were successfully matched with all the demographics you can think of: age and gender, prior opioid use, rate of depression, resiliency scores were matched, and comorbidities. And this is our primary outcome, which was pain at 24 hours. And what we found was, and it was a little surprise to me for sure, we found that the opioid-free group had significantly less pain at 24 hours than the opioid group. This was actually even present at the 12-hour point. 6 hours, the groups had similar pain levels, but at 12 and 24 hours, the opioid group had less pain than the opioid-based group. How about failures or patients that had to convert to opioids or required rescue opioids? We found 11 out of 126 patients did require even just one single pill of an opioid during their recovery. And so, that's less than 10% of patients did require some element of a rescue medication, and these were usually very temporary. Secondary outcomes. So Greg ran a few of these for us as well, and we found that the pain difference held through all the way to the first post-op visit. So from 12 hours to the first post-op visit, we found that the opioid-free group had less pain than the control group. By visit 2, they had equaled out. Incidence of falls, we found 6% rate of falls between the two groups and no difference there. Interestingly, we did not find a difference in the rate of constipation between the opioid-free group and the control group. And I was surprised by this. It may have to do with other medications that patients have to take during anesthesia, including ketamine and propofol and sevoflurane. A lot of those general anesthetics may also be contributing to the rate of constipation. Delirium, we had a very low rate of delirium, so no difference there. We did not have any patients that had any acute renal failure during their postoperative period. And so far in this study, and this is still preliminary data, but so far I think we can safely say that the randomized portion or process has been effective. The pain profile and the safety profile of the opioid-free pathway also seems to be very acceptable. So far we have some interesting findings. We've found that the opioid group has more pain, and it would be interesting to discuss why. No decrease in constipation. I think that may be due to other medications they require. And then there's a lot of other interesting unanswered questions that we're going to look through. Is this procedure specific? Did the total hip patients fare better than maybe the ACDF or the CMC arthroplasty patients? We don't know that yet. Are we going to find that the opioid-free pathway is indeed superior in many ways? Well, this could be important. What if we find that there's a difference in clinical outcomes? We're following all these patients out to a year. They're all getting clinical outcome assessments. What if we find that there's a difference in how the patients do long-term? What are the implications of patient resiliency? We measured this preoperatively in all the patients, and will we find that resiliency is predictive of their outcomes? How about barriers to enrollment? This is really interesting too. Are the barriers the patient's side of things, or is this continuing to be a more physician side of barriers? Meaning, are physicians more resistant to this pathway than the patients? For our next steps, we want to complete this prospective randomized study. And then we want to reload a little bit, and we have submitted a follow-up grant with the Duke Endowment, and we're going to focus on REAIM, which is going to help us do different things with this protocol. First, we want to see how many patients we can reach. So, is this something that we can roll out to far more surgeries, and is it something we're going to stick to orthopedics, or should we reach out even further than that? How effective is it going to be? How effective is it going to be with pain levels and potentially effects on clinical outcomes? How well are we going to be able to adopt this from the physician side and the patient side? implementation is difficult, and if we do large scale, if we try and scale this up, how are we going to be able to implement this on a large scale across a large healthcare network? And then maintenance, how are we going to be able to maintain this pathway and this protocol once this study is complete? We brought in Megan Wally from Atrium, and Megan has been instrumental with all the work that she's done with Dr. Shu and Dr. Seymour on the premium work. And we're happy to have Megan helping us with Core 2.0. You know, I mentioned earlier that there's different aspects to our core project, and one of them is community outreach and patient awareness. And this is an event we had back in the fall that we really geared toward the younger audience, high school and college students and athletes. And we had a great panel discussion. We included 3 former Carolina Panthers that really had some really interesting perspectives on their experiences with painkillers as football players, what they saw during their careers, and also now as fathers of teenagers, and what they see as the opioid problem that they can see among our youth. So we plan on continuing to have further events like this as we continue to roll through, and hopefully to the next phase of the core project. So this has been a huge collaborative effort. I'm just basically presenting the work of many people, and many people that are very passionate about this project. Everyone at Oaktree has been great. Christy has been there every step of the way. Katie Rains has done a great job marketing this whole project for us. Caleb has been our lead on managing this project through and through. Of course, we want to thank the Duke Endowment for giving us the opportunity to work on this project, and they've been great community partners with us. And lastly, I want to thank my partners, the surgeons at Ortho Carolina. I'm very fortunate to be part of the group of leaders and physicians that are really interested in pushing the needle on important topics like this. And so I can't thank my partners enough for their involvement and their enthusiasm with this project. Well, thanks very much. I look forward to the discussion.
Thanks, Natty. Fantastic. Really fantastic work that you're all doing. And just the way you went about coming up with this project, the design of the project, shows such a great collaborative effort. We're obviously from the Atrium side really proud of the role that many of the folks here have played, including Daniel Lees, who is instrumental in your initial project. I'd love to hear from Dr. Shu. Hopefully he's on the call. Yeah, I see his picture right there. Obviously a national leader in opioid awareness. Joe, any comments or questions for Dr. Hamid?
No, I think there's tremendous work, Natty, and your leadership in orthopedics has been tremendous with this. As you found out, implementation, a lot of these things is really where the challenge becomes, and it's surprising where we'll meet resistance with some of this stuff. And so to be able to communicate that effectively with colleagues and lead that is tremendous. So congratulations on that. One of the things I actually would like to open up some questions about is there is data on, because you mentioned about the gabapentin, is that something that you're going to remove in the future? Or I think we use it in a lot of other areas in orthopedics because it's been shown to shorten the duration of opiates, as opposed to all the studies. There's not really good data that it lowers your overall dose, but it does shorten the duration of opiates. And so we found it to be pretty effective in our opiate reduction, which is mainly focused on shortening those prescriptions as opposed to a completely opiate-free pathway. So I was wondering what your thoughts were on that, or if you use it in your patients that are getting a short course of opiates.
Thanks, Joe. I think we are going to continue the use of gabapentin in this pathway. We haven't seen a lot of side effects that we think from it, and we do use a short course of it in a low dose. So I think it's working well. You know, it's interesting. The implementation is going to continue to be the biggest challenge for us with this. And I don't know if Brian Curtin or Keith Faring are on, but the hip side of things was really interesting because we started really slow with our hip enrollment. And I think as the physicians saw that this was working well for their patients and they gained confidence in using it, the enrollment skyrocketed. And I think that's what you'll typically see with this. As the physicians understand and see how the pathway works for their patients and they see it firsthand, you then feel a little bit more confident about rolling it out in maybe a wider group of patients.
And Natty, it's Brian Curtin. It didn't take a whole lot to get these patients into this. A lot of patients were perfectly fine with it. They were open to it as soon as you even brought up the topic. And it really wasn't a huge change from what we were already doing. Just one comment on the gabapentin. I have had some older patients that told me that it really kind of messed with their head. So I'm very hesitant on the gabapentin section of the discharge, and really haven't seen a difference in terms of the patients that take it or don't take the gabapentin. So I'm not sure it's a huge issue with the total hips.
Yeah.
Natty, this is T, and I've been reading some articles in the recent literature on some of these joint cocktails and what their role might be in management. Have you had any experience there? And do we have any prescribed cocktail for total shoulders or total joints?
So we're using, when we initially wrote the protocol, we had Exparel in there, and we've phased Exparel out due to the evolving evidence over the last several years on that. So we're actually using the SERT injection, the same one they're using for the hip, we're using for the shoulder.
Natty, since we were having a discussion about Neurontin, let me ask you about that. So, frequently, we've used that too in orthopedic oncology. I guess we're always sort of leery of hysteria driven by lawyers and lawsuits. And that is one of those that is commonly out there. There's probably no drug that I give people that I get more questioning of the prescription than gabapentin, because they do a little bit of a look on it. This is a question for you and maybe any others. If you have a common answer. I mean, my typical answer is that it is a very old drug. It is a seizure medicine. It is important to sort of ramp up and ramp down when you take it. It's not a PRN medicine. But I have a low threshold if somebody expresses concern to just stop it. Anybody have any better thoughts? I have felt like it has been, of course, anecdotally, that it's been a good adjuvant medicine. And I know Dr. Shu uses it frequently. Anybody have any comments on how they address that sort of medical legal issue?
I'm happy to chime in, Natty, unless you wanted to go first.
Go ahead, Joe.
Yeah, I think you're right when you say there's a little bit of hysteria around it. It's kind of the same hysteria that we experienced in the 80s and 90s around NSAIDs. I mean, there wasn't a faster way to get orthopedic surgeons to set themselves on fire than to mention the word NSAIDs around fracture healing or integration of implants and things like that. And so that's a little bit has occurred in the past 3 or 4 years. The reality of gabapentin is it does have side effects. It can cause sedation, especially in your elderly people. And so start low and go slow. If you have trouble, then stop it. The interesting thing is some people's response to not using gabapentin is use more opiates, which we know 100% of the time has sedating effects in that same elderly population. The upside to gabapentin, again, we talked about, shortens the duration potentially, not the dose that people take of an opiate, but shortens the duration. And for conversion to long-term use of an opiate, actually the dose is not related to long-term conversion. The dose is related to overdose. It's the duration of the initial treatment or the initial prescription that's been associated with converting to longer-term use. So that's really the strategy that we that we tend to employ with it. But there's a lot of safety data with relatively high doses over long periods of time. The package insert is fairly extensive if people are really interested, and it's been studied pretty well. But there's no free lunch. With any medication, there's no free lunch. And so there are, it actually does have street value, believe it or not, because if heroin addicts get it, it can potentiate their opiate high because it kind of lengthens it a little bit for them. And so there's no free lunch. Natty, had a follow-up. Go ahead.
Yeah, we just, I take the same approach, and many of us do that Dr. Kern mentioned. You know, if a patient mentions anything about feeling like the gabapentin is bothering them, they stop it. And a lot of these patients in the opioid-free group, they're off essentially everything in about 3 to 5 days. You know, they're taking Tylenol and they're taking maybe meloxicam, and that's about it. And so we give them a short course, and again, it's about the lowest dose we give. And if they have any side effects, they essentially stop taking everything. When we call folks back at 3 days after surgery, frequently they're on nothing but Tylenol and Mobic.
Natty, my question for future directions, especially with the next grant, is there a thought of incorporating non-pharmaceutical strategies for pain management, like physical and cognitive strategies, aromatherapy, meditation, things that are very scalable, cryotherapy, TENS unit, things that are very affordable and scalable for patients that really have minimal to no side effects?
Yeah, we're planning on doing all that. Exactly, Joe. It's we want to try and have a sort of a clearinghouse place where patients can have similar to what you've shown as links on the Atrium website. We're going to build something out that's going to have a lot of those resources for them. We're also going to look at non-pharmaceutical options as we roll this out to other procedures as well.